Today we are very happy to have Mr. Stephen Lau to introduce to us about the prevention and management of extravasation injury. Stephen is a pharmacist from CU Champion of School of Pharmacy in CHK. Hello, Stephen.
Hello, Suzanne.
Could you tell us about what extravasation is?
Extravasation is the escape of drug into the extravascular space, either by leakage from a vessel or by direct infiltration.
Could you tell us about the classification of extravasated drugs?
Extravasated drugs are classified based on their potential to cause local toxicity. They are classified into vesicants, irritants, and non-vesicants. A vesicant drug has the potential to cause tissue necrosis with a more severe and non-lasting injury. An irritant drug can cause inflammatory reaction with aching, burning, tightness, pain, and pruritus at the needle insertion site or along the vein, but it will not cause tissue necrosis. However, some irritant drugs may cause tissue necrosis if large volumes of concentrated solutions are extravasated. Non-vesicant drugs rarely cause acute reactions or tissue necrosis even when extravasated.
So could you give us more examples about common vesicant drugs?
Examples of vesicant drugs include anthracyclines such as doxorubicin and daunorubicin, vinca alkaloids such as vincristine and vinblastine, taxanes such as paclitaxel and docetaxel. Other examples include mitomycin C and metocentrone. Some long antineoplastic drugs can also act as vesicants. They include radiographic contrast media, concentrated electrolytes such as calcium gluconate 10%, and nutritional solutions such as total parental nutrition.
How do vesicant drugs cause tissue damage?
Vesicant drugs cause tissue damage in different ways following extravasation. Firstly, the drug is absorbed by local cells and binds to the critical structures such as DNA and microtubules, causing cell death. After endocytolysis, surrounding cells may also die due to the release of the drug from the nearby dead cells. The process may result in progressive and chronic tissue injury. The second way to cause tissue damage is that the drug does not bind to the DNA, but to be metabolized and cleared. The degree of tissue injury may be more limited in this case.
Stephen, are all patients receiving vesicants at risk for extravasation injury?
Yes, every patient who receives a vesicant drug is at risk of extravasation.
So what are the risk factors for extravasation from a peripheral vein?
The risk factors for extravasation from a peripheral vein include small or fragile veins or limited vein availability because of lymph node dissection, lymph edema, or lymph removal, obesity, which obscures veins from view and palpation, multiple previous venipunctures, disseminated skin disease, for example, eczema or psoriasis, patient movement, and sensory deficits that impairs a patient's ability to detect a change in sensation at the site of chemotherapy administration, for example, paralysis, shock, sedation, somnolence, impaired cognition, and impaired mental status.
And then what are the risk factors for extravasation from a central venous access device?
Risk factors for extravasation from a central venous access device include difficulty encountered during the insertion of the device, such as probing or inability to advance the guide wire or catheter. Catheters can also become inadvertently sliced, pierced, or leaked before or during insertion. Device misplacement with the catheter tip placed outside of the venous system instead of the superior vena cava. Catheter migration from the vein into the tissue. Long dwell time, days 6 months or longer. Soft catheter materials are prone to weakening and pinch-off syndrome, which occurs when the catheter is compressed between the clavicle and the first or second rib. The presence of a fibrin sheath or thrombus at the catheter tip, which may cause vesicant chemotherapy to backtrack along the catheter and leak from the vein at the venotomy site. are deeply implanted ports, which increases the risk that a long-coring needle will be of insufficient length to be correctly positioned into the port septum, or that the patient movement will cause rocking of the needle within the port septum.
We don't want our patients to have extravasation, so could you advise how to prevent extravasation?
To minimize the risk of extravasation, careful, standardized, and evidence-based administration techniques should be adopted. The staff responsible for infusion and management of cytotoxic drugs must be trained to implement preventive protocols. The European Oncology Nursing Society has provided guidelines for preventing extravasation. Firstly, the most appropriate site of insertion should be chosen. If the venous access was found difficult, central venous access device should be considered. For the site selection, large veins in the forearm are recommended for peripheral administration. Cannulation should be avoided over joints, inner wrist, and the lower extremities. Veins in the antecubital fossa or on the dorsum of the hand are also not recommended. Cannulation should also be avoided when lymphedema is present. Second, for the cannula selection, ring steel infusion devices, also known as butterfly needles, should not be used for infusion of vesicant drugs, as the needle can be easily displaced or puncture the venous wall. Instead, flexible cannula should be used. For infusion of vesicant drugs of longer duration, central venous access device is highly recommended. Procedure-wise, after cannulation, check for blood flow. Then flush with 10 ml of normal saline and check for signs of extravasation. Flushing with 10 to 20 ml of saline solution between different drug infusions is recommended. A blood return should always be obtained before drugs are administered and checked regularly throughout the bolus infusion. Bolus dosages of vesicant drugs may be administered concurrently with a fast-running infusion of compatible IV fluid. During infusion, continue monitoring of the cannula's insertion sites and check regularly for the appearance of symptoms such as swelling, pain, redness, or sluggish infusion rate.
Stephen, thank you very much for your sharing. So let's work together to prevent and manage extravasation in hospital settings.